Welcome to the Department of Medicine Grand Rounds. We have a special guest today. But before that, a few comments. Number one, I want to remind everyone that next Thursday is Awards Day. So instead of Grand Rounds, we will have Awards Day. It's a great opportunity to come with faculty and trainees and say hello and celebrate people because of their accomplishments, but also say goodbyes to some of our senior residents who are going off to do great things. So please join us next Thursday. I will be in Atlanta next week, and I'm flying Wednesday night just to be here on Thursday morning, okay? So please come. On this day was the birth in 1942 of Stanley Prusiner. And Stanley Prusiner was an American neurologist who discovered prions in 1982, which is interesting because until then we had the impression that all these pathogens had a genetic material. And in fact, prions don't have genetic materials. Sir Humphrey Davy was killed on this day in 1829. And he's interesting because he discovered a number of chemical elements. He actually used electric current to actually identify sodium, potassium, calcium, strontium, barium, magnesium, and all these things which we all take for granted today. But somebody actually had to find them and decide what to do. And these kidney people sort of worry about these things day in and day out, which is sort of interesting, okay? But our speaker has done some work with mass spectrometry to identify biomarkers of lupus nephritis. And it's interesting to me that Alfred Neer was born on this day, and he was an American physicist who actually refined mass spectrometric processes to isolate and identify isotopes. So it's sort of interesting. And with that, I'll give you Eleanor Lederer, our chief of nephrology, who's going to introduce our guest.
Thank you, Jesse. I'm really delighted to introduce to you guys Brad Rovin, whom I have known for a number of years. Brad is, as indicated on the slide here, he is Division Chief of Nephrology at The Ohio State University and is also the Vice Chairman for Research there. This barely touches the surface of what Brad is involved in, which is a lot. At the level of the NIH, at the level of the Ohio State University, the American Society of Nephrology, and other national organizations. His medical training was at the University of Chicago, followed by residency at WashU, and he went to the Ohio State University in 1990, where he has been since then. In particular, of note, is that he has developed an interest not just in glomerular disease, which he'd had for a long time, but also specifically in the field of lupus nephritis and in biomarker discovery. In that, he has collaborated with one of my colleagues here, Dr. John Klein, on a UO1 to identify biomarkers of glomerular disease. In addition, he is collaborating with another one of my colleagues, Dr. Michael Breyer, in a study looking at algorithms for anemia dosing. I would like to take this opportunity to remind everybody in the Department of Medicine that we have developed a multidisciplinary lupus and glomerular disease clinic that is manned by those three individuals that are sitting right there next to each other, who also look to form collaborations with Dr. Rovin as well. The multidisciplinary clinic is in lupus nephritis and involves not just the nephrology division, but also the rheumatology division, and is involved also in this biomarker discovery consortium. So with that, I would like to introduce and bring up to the stage Dr. Brad Rovin.
Thank you. So thanks very much for having me. I was here several years ago, and if you want to hear about any of the stuff, biomarkers, come to Renal Grand Rounds tomorrow, because that's where we'll talk about it. Today I wanted to give you my perspective of where we are in the management of lupus nephritis now, and kind of challenge a little bit of what we think about. Hopefully you'll agree or disagree with some of this and we can have a good discussion. I think some of these ideas are a little bit novel even for the nephrologist, so we'll see how this goes. I'll start off with a case because they always like our grand rounds to start off with a case. A 20-year-old Hispanic female diagnosed with lupus 4 months ago. Her clinical manifestations were a facial rash, pleurisy, an ANA, and a positive DNA. Urinalysis was not remarkable at the time, and her serum creatinine was shown. She started on a modest dose of prednisone for these extrarenal symptoms. She had good resolution of the symptoms, but hated the steroids. We all know that. Okay. She rapidly tapered the prednisone. She was seen in follow-up, and she had new pedal edema. Her urinalysis now showed blood and protein on the dipstick, and on microscopic examination, there were acanthocytes and 1 white cell cast on microscopic exam. And I'll show you some examples for those of you who don't look at urines very often. Serum creatinine was now 1, complement levels were low, albumin was 2.9, and the spot protein to creatinine ratio was 5. A kidney biopsy was done. So, I want to talk a little bit about the diagnosis, start everybody off on the same page. This is kind of what we propose to evaluate the lupus patient for nephritis. We think that testing for lupus nephritis is indicated at the initial presentation of lupus always, and then yearly, and then anytime there's a suspicion of a flare, whether it's renal or extrarenal. The screening panel is very simple, just serum creatinine and urinalysis, and when I mean urinalysis, dipstick and sediment, which I realize now has been relegated mostly to the clinical laboratories because even at Ohio State, they have told our division we are not sufficiently qualified to look under a microscope and do a urinalysis. So we keep ours locked up, hidden away. Evidence of abnormal proteinuria on the sediment, a dipstick protein greater than 2+, greater than equal to 2+ at any specific gravity, or 1+ if the urine's dilute, and then with or without sediment that's positive for various formed elements. Evidence of a decreased GFR, and this is a little trickier because there can be a lot of reasons for renal impairment in a patient with lupus. So you want to be able to attribute the change in creatinine or GFR to the disease. And just to give you all a differential so you can think about this, the patients are often treated with immunosuppression, so infection and hypotension may be the cause of impaired GFR, volume depletion, nephrotoxins. I wrote contrast media, but a lot of times some of the non-steroidals are given to the non-renal lupus population in large quantities. And then just because of lupus, they can have hemolysis, thrombosis, and heart failure. We'll talk a little bit more about non-lupus glomerular diseases in a few minutes. So there's a variety of different sorts of things that can cause renal impairment in lupus that don't have to be lupus nephritis. Okay, what is the prevalence of renal abnormalities in lupus nephritis? And I think this is a pretty interesting slide. So everybody has proteinuria of some type. About half the patients will have nephrotic range proteinuria. Some of those will have nephrotic syndrome. Almost everybody has blood in their urine. Very seldom do we see macroscopic hematuria. And then, of course, we look for casts under the microscope. They're seen in about a third of the cases, but a lot of times the casts are evanescent, and they fall apart before we get to see them if the urine's been sitting around for a while. This is an interesting number. It's listed as 40 to 80% of the patients with impaired kidney function when they first present. And I think part of the problem is most of these patients are young women with not a lot of muscle mass. So what their normal creatinine is pre-disease may be very low. And so when you have a person whose creatinine upon presentation is 0.8, and you say, well, that's within normal range, it may not be for that individual. A lot of our patients' normal creatinine is 0.5, 0.6. So that may be a real change, and it would be nice if you had measurements from pre-illness to go by. And then some of these other abnormalities. Okay, for the non-nephrologists, I think this is fun because it's kind of interesting to look in the urine. There's a whole bunch of dysmorphic or misshapen red blood cells that exist in the urine, but one of them, called the acanthocyte, is pretty specific for glomerular bleeding. And this is what we look for. This is under regular light microscopy. So a normal red blood cell is a biconcave disc, and then if it passes through the glomerular basement membrane, it gets damaged and it blebs. And this is called an acanthocyte. And these types of cells are very specific red blood cells for glomerular disease. A red blood cell cast, of course, is a collection of red blood cells that you can see in the urine, but these tend to fall apart fairly quickly, and they're few and far between, so we don't see them very often. White cell casts are cellular casts with bigger cells. They're granular, and you're looking for a white cell cast in the absence of any sign of infection, because you can also have white cells and white cell casts if a person has a urinary infection, more likely pyelonephritis if you have a white cell cast, and of course, young women tend to get UTIs, so that's very important to rule out. This is the muddy brown ATN cast that everybody teaches you about when you're in medical school, that's associated with acute renal failure. These are not usually seen as part of lupus nephritis. If they are present, you need to consider the following differential, and this is similar to what we talked about for other reasons that the patient might have acute kidney injury, infections, bacteremia, sepsis, hypotension, clotting, etc. I love these pictures, and I just show them because they're great pictures, and I think it really hammers the point home. This is an electron micrograph. These are all from lupus patients. This is a normal or a capillary with normal red blood cells inside the capillary. Here's a red blood cell that's squeezed through its in Bowman space, and if you can imagine, we didn't grab it out with a biopsy. This would be urinated out, and it would be an acanthocyte. You can see the acanthocyte forming. So I think that's pretty neat. And this is what it looks like, and this is a scanning EM of an acanthocyte. So if you draw some eyes and a smile, it's Mickey Mouse, and hopefully you'll remember that. This is a red blood cell cast that is inside the tubule. It's not a cast yet, but if you urinated it out, it would look like that. And so that's what we can see on the biopsy. Okay. This is a pretty controversial issue, assessing proteinuria, and it may be controversial because of us at Ohio State, because we don't like the spot protein to creatinine ratio. And I'm going to throw this out there, and I'd love to hear what the nephrologists think about this. So when lupus first was lupus nephritis years ago with the ACR criteria, it was merely proteinuria on a dipstick that made or didn't make the definition. The renal community has moved to a random spot urine protein to creatinine ratio, and we have published in our group a lot of literature suggesting that random spot ratios are pretty inaccurate measures of what's going on with the proteinuria. The gold standard, of course, is a 24-hour urine protein. The problem with that is the belief that people don't collect these accurately, and I think by and large that can be true, but you can train your population to do it accurately, and the patients don't like to do it because they have to store the urine and collect it for a day, et cetera, et cetera. We tried to correct for that using the 24-hour protein to creatinine ratio, and I will tell you our group has been a big advocate of this, and in fact most of the recent clinical trials looking at the quantification of proteinuria in lupus actually use this, and now we've moved to something called, we call it, the 24-hour protein corrected. And just to show you why we don't like the random spot protein to creatinine ratio, we took several studies, we published this in Annals of Rheumatic Disease. This is the spot protein to creatinine ratio over the 24-hour urine protein to creatinine ratio. And on the x-axis is the 24-hour PCR. So if the spot reflected what is going on in the 24-hour urine accurately, this is the line you would see. And of course, you see there's really no relationship between the two. So the spot urines are fairly inaccurate, and hopefully we'll have an abstract talking about how this influences your decision of response to therapy at this year's ASN. So why not use a 24-hour protein to creatinine ratio? It's good if the 24-hour urine creatinine excretion is about 1 gram a day. But in our own cohort, the mean urine creatinine in a lupus population, and remember, these are by and large young women, is about 1.25 grams a day, and this was close to 800 patients. So if you use the protein-creatinine ratio, you actually may underestimate proteinuria. And just as an example, the proteinuria is truly 3 grams a day on a 24-hour urine, but the urine creatinine is 1.28, the PCR is 2.4. That's really the difference between a non-response to a therapy and a partial response. And I realize we can talk about the definitions of response and non-response. They may not be very good either. But you get the point. So how do we want to fix this? Well, this is what we propose. We've put this out in the literature. We'll see if people pick up on this. We want to determine the completeness of a 24-hour urine collection. So you measure the total creatinine content of the collection. You calculate what you expect the creatinine content to be using the old Hakoff-Gault equation. If you remember that from medical school, maybe you're too young, they don't even teach that anymore. But it was a way of estimating creatinine clearance by age, weight, and serum creatinine. And if you solve that equation for the urine creatinine, you get a pretty good expected creatinine excretion for that patient based on body mass and their age and their serum creatinine. So then you can compare the measured creatinine content to the expected creatinine content. If it's more than 50%, you can use the urine collection clinically. So we propose that you collect and calculate the PCR of a 24-hour urine, multiply it by the expected PCR, and actually have a proteinuria in grams. For the non-nephrologists in the audience, as well as the nephrologist, this sounds tedious, and I suspect it's not going to catch on, but this is what we think about. So the other things to think about is that you have to actually change this, reduce the magnitude if the patient's a vegetarian. There's some more practical things about assessing renal function that I think might be useful to the audience. Serial measurement of serum creatinine, I believe, is a useful way to monitor renal function. It gets a lot of critique now because everybody wants to use estimating equations for the GFR, and I suspect you have them in your laboratories as well. Now, just a point, serum creatinine could be increased or decreased by conditions that are independent of the GFR. So, for example, tubular secretion can be decreased by several types of drugs, including trimethoprim. We prophylax patients for PCP. I realize it isn't called PCP anymore. With sulfa drugs, that can increase serum creatinine. Tubular secretion is increased by hypoalbuminemia. Patients generally have proteinuria. Their serum albumins may be lower, so this could artificially decrease serum creatinine. This is important in the early treatment of lupus nephritis when we're using very high-dose corticosteroids. This affects skeletal muscle metabolism. Serum creatinine can increase. So we can artificially see an increase in creatinine when we first start treating the patient with high-dose steroids. And you have to understand that and not say, well, the treatment has failed. I need to move on immediately to something else. And then if you have a diet high in cooked meats, your creatinine can go up. Vegetarian diets, creatinine can decrease. The estimating equations, what you see as the eGFR from MDRD or any of the series of new iterations of MDRD, are now routinely reported. None of these have been validated. You need to make that clear. None of these equations have been validated in what is a typical lupus population of young women, okay? This was not how the equations were developed, and even though there are several papers in the literature from rheumatology groups suggesting these are valid, they've never actually been compared to an inulin GFR. All of these equations are based on serum creatinine, all of them. So all of the weaknesses of serum creatinine still apply, and these all assume that patients of the same age, race, sex, and serum creatinine have the same rate of creatinine production, and that's not true. So there's problems. We as a community realize there's problems with measuring renal function clinically, and we have gone to the eGFR, but serum creatinine is still pretty good until we have something that's better, and it isn't cystatin C, which is getting a lot of press as well. This is the biopsy conundrum. True or false? A kidney biopsy is needed in the diagnosis. What do people here think? Not the group that does this for a living. Do we need a kidney biopsy for lupus nephritis? Yes, no? No, you let the nephrologist decide. Okay. So many of my colleagues in rheumatology complain to me that nephrologists won't do a biopsy anymore. They said, you know, they treat patients with MMF, everything's okay. So let me just point out why you need a biopsy, and not simply for research purposes, which we'll talk about tomorrow at renal grand rounds. This is a 50-year-old Caucasian woman, alopecia, positive ANA, double-stranded DNA, low complement levels. He had antiphospholipid antibodies, lupus anticoagulant. She was hospitalized with AKI, and it wasn't related to lupus or lupus. She didn't have known lupus nephritis, but she had had some complications post-op. Her serum creatinine increased and then fell, like we would see in a patient with ATN. She had a pericardial effusion, a drain was placed, so that might have been lupus-related. And then at some point down the road, she was found to have hematuria and a proteinuria of over 1 gram on a 24-hour urine protein, 24-hour urine collection. So she now had manifestations that could potentially be related to lupus nephritis. We did a biopsy. I won't go over this in great detail, but what this biopsy showed, if you look here at the immunofluorescence, there was some mild mesangial IgA. This was not a full house. She actually had sclerotic glomeruli and arteries that had evidence of old clot. What she had was a chronic thrombotic microangiopathy, probably from her lupus anticoagulant. She did not have lupus nephritis. If she did, it may have been class 2, but there was no active inflammation. So to assume this patient might have had a lupus nephritis and treat her with high-dose immunosuppression would have been incorrect. So I believe a biopsy is needed for several of these, for all of these reasons. So not all kidney disease in patients with lupus is lupus nephritis. And in fact, it turns out that about 5% of patients with lupus can have other glomerular diseases. Most prominently, they're minimal change disease and focal segmental glomerulosclerosis. It's been called lupus podocytopathy in these particular cases, but these generally respond to steroids alone, and you don't need to add immunosuppression. So they would be a good thing to diagnose prior to starting therapy. Obviously, antiphospholipid antibody syndrome and the nephropathy can occur in the presence or without lupus nephritis, and you can get interstitial nephritis with lupus, although without glomerular disease, that's fairly rare. Not all kidney disease and lupus nephritis needs to be treated aggressively with immunosuppression. For example, class 2 lupus nephritis is there. Generally, it's not an issue, and we treat the extrarenal symptoms, syndrome, not the lupus nephritis. And then, of course, if you have chronic changes with little active inflammation, but you can still have proteinuria because of the glomerulosclerosis, you don't want to treat these patients aggressively with immunosuppression. So that's the reason to do a biopsy. Is there a threshold level of proteinuria for which you should consider a biopsy? Well, the answer is no, not necessarily, but we use about 500 milligrams in our clinic. And here's this was from ASN a couple years ago. Unfortunately, I haven't seen the paper, but nonetheless, this was a series of lupus patients where they looked at proteinuria of less than 500 milligrams. The patients had normal kidney function, glomerular hematuria, and these were all the very first biopsies. This was the first diagnosis. And it's a small series, 38 patients. But look at the kind of lupus classifications that they were getting. Class 3 and 4, which are the aggressive proliferative forms of lupus nephritis, were seen in more than half of this population, suggesting that there's a discordance between the pathologic findings and the clinical findings. Therefore, we tend to be very aggressive with doing biopsies to make the diagnosis. We'll talk more about pathology discordance a little bit later. Okay, getting back to the case. The biopsy in this patient was consistent with a combination of class 4 and class 5 lupus nephritis, high activity, low chronicity, High activity means a lot of inflammation. Low chronicity means there's very little chronic damage to the kidney at this point, and there was a cellular crescent. And just to make sure everybody who's not a lupologist is on the same page, these are the various classes of lupus nephritis. Class 2 is probably the minimum class we'll see with a biopsy because class 1 usually doesn't show any clinical signs. You can have proteinuria and hematuria. Renal insufficiency and nephrotic range proteinuria or nephrotic syndrome are distinctly unusual in class 2. This is really seen as mesangial expansion with some mesangial dense deposits, immune complexes, and again, no specific treatment is needed. The proliferative lupus nephritis, class 3 and 4, are distinguished by a bunch of features, but class 3 is less than 50% of the glomeruli involved, class 4 is more than 50% of the glomeruli. This has a lot of endocapillary proliferation, so you don't no longer see the lumens of the capillaries. And when you look at under electron microscopy, you see these dense immune complex deposits in the subendothelial space. Class 5 lupus nephritis is called membranous lupus nephritis. You see that the glomerular capillary loops are opened, but you have a lot of deposits in the glomerular basement membrane or in the subepithelial space. This is generally a less inflammatory lesion, and this is what it looks like. And then you can have the combination of, and this is really a very nice picture of subepithelial and subendothelial deposits. So you can have proliferative glomerulonephritis along with membranous, and we see that a lot. Class 6 is what we want to prevent. This is interstitial fibrosis, dilated tubules, essentially end-stage kidney. Okay. So the patient was told she has lupus nephritis, and we recommended high-dose prednisone and mycophenolate mofetil. She refused the steroids. She said that on 20 milligrams a day, she couldn't sleep, she couldn't study, she couldn't do anything. So what should we do with this patient? Should we treat her with MMF alone, cyclophosphamide alone, or should we discuss a steroid-sparing protocol? Anybody want to volunteer? I didn't give you very good choices. Okay. But obviously, this is the weird one, so we'll discuss this a little bit. What is the treatment of proliferative LN today? Okay. So first of all, what are the goals of therapy? The goal of therapy is to preserve long-term kidney function and avoid dialysis and transplantation in these patients. Secondly, we want to minimize chronic kidney disease. Chronic kidney disease increases the risk for cardiovascular mortality and morbidity, and these patients are already at risk for cardiovascular disease because of lupus. Lupus itself is a risk factor for premature cardiovascular disease. I don't know if this is well known outside the nephrology community. We tend to keep things secret, but there is a relationship between GFR and cardiovascular events. These are hazard ratios for cardiovascular events over 1 million ambulatory adults. This is eGFR ranges. So if you set ostensibly a normal renal function at a hazard ratio of 1, the risk for cardiovascular events increases when there's very modest declines in GFR. And then as the declines in GFR increase, as you approach end-stage renal disease, the risk of cardiovascular disease increases. And in fact, many of our patients with chronic kidney disease don't make it to dialysis because they die of other causes, primarily stroke and heart attack, that sort of thing. And these hazard ratios were adjusted for a lot of variables. To bring this point home even more, these are the stages of chronic kidney disease from KDOQI, which is one of our standard organizations that gives out guidelines. And stage 1 is structural or functional kidney abnormalities for more than 3 months with normal renal function. I will submit to you that if you have lupus nephritis 1 episode and you finish and you're successful, you already have structural abnormalities of your kidney. And you can see that even in stage 1 and 2, CKD 1 and 2, which is in the purple, the prevalence rate of MI, peripheral vascular disease, and stroke is increased significantly. So I think this is not thought about when we talk about lupus nephritis. We're often very happy with partial remissions. Partial remissions mean impaired renal function and continuing proteinuria. And that may not be a good thing for these patients. And I think I say that here. I think we're losing sight of the goals that I listed, prevention of renal replacement therapy and prevention, if we can, of chronic kidney disease in favor of short-term endpoints of complete and partial response. I believe this is driven by our quest to understand if we can have new therapies and the fact that it's economically difficult for a pharmaceutical company to run a long-term trial. So we need short-term surrogates. This is the strategy we currently employ to achieve these therapeutic goals. We have an initial therapy. We'll talk about this in a minute. If the patient gets worse at any time, you can choose an alternative therapy. We call this induction. We use it for 3 to 6 months. The patient gets better, remits to some extent. This is partial or complete remission, or is stable. Then they go on to maintenance therapy. And hopefully, after some prolonged period of time, they're in complete remission, and we consider tapering off therapy. Or they stay on therapy indefinitely, and this is not minor league therapy. This is therapy that is relevant and dangerous, and it's like a transplant patient, potentially lifelong immunosuppression. These are the current definitions of a complete renal response. American College of Rheumatology. These are from various trials that have occurred recently. You can see that they're all different, and that's really a problem. What we need in the community is which, if any of these options, actually predicts long-term kidney survival. So we don't have that answer yet. In fact, we're leading a group in the Kidney Health Initiative to try and get that answer, and we may have data for the ASN this year, but that remains to be seen. We're in the statistical analysis phase right now. But we did kind of a look back at the Lupus trial. Lupus was a trial which compared low-dose cyclophosphamide to standard high-dose cyclophosphamide in the treatment of lupus nephritis. It doesn't matter what the treatment is. We re-examined this was the name of the trial, ELANT. We re-examined these patients who had a minimum of 7 years of follow-up, and that was 76 patients. So this is good long-term follow-up. All of them had lupus nephritis, biopsy proven at entry. And we evaluated the usual clinical variables at 3, 6, and 12 months, individually and in combination, to determine if any of these were clinical biomarkers that would predict good long-term kidney function. And we define good long-term kidney function as having a creatinine less than or equal to 1, 7 or more years down the road. Now, we can argue about what is good long-term kidney function. That's not bad. You can argue that if the patient's real creatinine was 0.6, that's not good, but this is what we chose. We assess biomarker performance using receiver operating characteristic curves. We maximize the sum of sensitivity and specificity, and we determine optimal cutoff values for proteinuria, creatinine, et cetera, to give us good long-term outcomes. And this is what an example looked like. This is looking at proteinuria at 12 months as a predictor of long-term kidney survival. So a single variable. This is the ROC curve. The area under the curve is pretty good. A perfect area under the curve is 1. That you don't see that in clinical medicine, but that would be something that did this, okay? So it turns out that the maximum sum of sensitivity and specificity was right between 0.7 and 0.8 grams a day of proteinuria at 12 months. Now remember, all of the preceding indicators of proteinuria that I showed you in that table were at 12 months a urine protein that was less than 0.5, a urine protein that was less than 0.2, et cetera. So this is where we saw this, but even more importantly, perhaps, is we looked at a bunch of the variables, and we also looked at them in combination. And what we found is proteinuria less than 0.8 gram a day gave us very good sensitivity and specificity and correctly classified or predicted the outcome of the patient at 7 or more years. If you were more rigorous in your proteinuria definition, you were pretty close, but not quite as close. Serum creatinine didn't do any better. Serum creatinine at 12 months didn't do any better than proteinuria. And red blood cells. This has been a very difficult issue. The FDA wants to know that the red blood cells in the urine go away for remission in lupus nephritis. We have argued for a long time that on a multi-center trial, it's very difficult to get quality urinalysis. And number two, patients can remit and do very well, but the proteinuria or the hematuria remains for a period of time. It takes a long time to get better. So red blood cells by themselves didn't have good predictive value, and they shouldn't. But when you add red blood cells to proteinuria of 0.8 gram per day, it actually makes everything worse. And when you add it to proteinuria plus creatinine, it makes everything worse. So what do we hope to get out of this study? How do I interpret this study? Well, or for you, can we apply these data now? So what these data show is that in a largely Caucasian population with mild to moderate lupus nephritis, because that is the northern European population that was enrolled in this study, if you achieve 800 milligrams or less of proteinuria by 12 months, you are probably going to do okay. Now, I don't think these are necessarily reproducible in other ethnicities or races, especially in the populations we see in this country of African American and Hispanic patients, which tend to have much more aggressive disease than these patients had. So I do think, however, that this gives us the idea that for different individuals or different groups of people, there may actually be different endpoints that we need to achieve to preserve kidney function long term. So I think that needs to be considered. Obviously, this needs to be repeated in another large lupus population, and we're doing that right now. The other thing I think we should point out is that we can't apply this to treatments that decrease proteinuria by mechanisms other than directly addressing the immunologic problem. So, for example, the calcineurin inhibitors have been used widely in Asian countries now to treat lupus, and a paper came out for which we're hopefully writing an editorial suggesting that calcineurin inhibitors were as good as cyclophosphamide in treating proliferative lupus nephritis by themselves. Calcineurin inhibitors, of course, are cyclosporin and tacrolimus, and unfortunately, they're good. We use them in transplant, but they can decrease proteinuria by 3 mechanisms, only one of which is altering the immune milieu. The other mechanisms are potentially a direct effect on the podocyte cytoskeleton, and then they have a profound hemodynamic effect, at least early on, to decrease GFR, and when you decrease GFR, you decrease proteinuria. So a proteinuria endpoint may not be an appropriate endpoint depending on the therapies that are being trialed. And of course, in pure class 5 LN, which is a proteinuric disease, these might not be good. However, we've taken these data and shown the FDA, and what we're trying to do is show them that having a requirement for a clinical endpoint of hematuria in these trials of novel drugs may actually impede our progress in identifying and qualifying novel drugs. So I think that is something important that can be taken away from this, and hopefully the FDA will buy that, and we can move away from that. Okay. The nonspecific treatment of lupus nephritis, I'm going to put a pitch in for antimalarials, hydroxychloroquine. The nephrology community has not embraced this very well. We did put it in the KDIGO guidelines, but the rheumatology community knows that hydroxychloroquine or the antimalarials, there's been a number of studies that show benefit in patients specifically with lupus nephritis. So this is the percent of patients who developed end-stage renal disease, whether they were being treated or not treated with an antimalarial. And you can see here that the patients who were not treated did worse and had more ESRD than the patients being treated with an antimalarial. And this also extended not only to renal survival, but to patient survival rate. These are patients that were not treated with the antimalarial, and these are patients treated with the antimalarial. There was a very large Canadian withdrawal study, that was the name of it, where they took patients who had been stable on hydroxychloroquine or an equivalent antimalarial, withdrew the antimalarial, many of the patients flared, and many of those flares were nephritis flares. So I believe a patient should be on an antimalarial unless there's a contraindication. These are the general targets and things we do as nephrologists to preserve renal function in patients with proteinuria kidney disease. We like the blood pressure to be under control. We like the blood pressure to be under control with RAS blockade, dietary sodium restriction, et cetera. I'm sure your nephrologists, when you make rounds with them, drill this into you because that's pretty common practice now. I took all of the guidelines. In 2012, simultaneously, ACR, American College of Rheumatology, the Kidney Organization, and the European organizations all came out with guidelines on the treatment of lupus nephritis. Although some of us worked on several of the committees, by and large, they were independent, and they came up with pretty much the same things. So if you have severe proliferative lupus nephritis, you might use intravenous methylprednisolone, and then start with high-dose corticosteroids. All the recommended regimens have corticosteroids. You see, I'm hopefully worming my way back to the case. Corticosteroids that are tapered over weeks to months. And then you add an immunosuppressive to the corticosteroid. This part is called induction therapy. You can use intravenous cyclophosphamide in high dose. This is called the NIH regimen. You can use oral cyclophosphamide in moderate dose. This is what we do. You can use low dose intravenous cyclophosphamide, which is the Lupus regimen. I'm going to put a little plug in because I think I'm on time so far. This is a very interesting regimen for those of you who haven't been exposed to it. In the high-dose NIH regimen of cyclophosphamide, we give the patients a gram per meter squared each month intravenously for 6 months. And that usually comes out, depending on the size of the body mass of the patient, et cetera, this will come out to 9 to 12 grams of cyclophosphamide over a course of time. Oral cyclophosphamide given in these doses is about the equivalent of the intravenous cyclophosphamide. Low dose Lupus is what it's affectionately known as. 500 milligram fixed dose every 2 months for 3 months, and then you're done. So you get 3 grams of cyclophosphamide totally. That is true low dose. We just published the results of a abatacept add-on trial in lupus nephritis. Unfortunately, that didn't work. Abatacept, which is a co-stimulatory modulator, didn't actually add anything to induction therapy in that particular trial. But the control arm in that trial was using low-dose cyclophosphamide in an American population that had a lot of African American and Hispanic patients. So they took the Lupus regimen and we put it in our population. And remarkably, the patients who were treated just with the placebo plus Lupus did as well or better than historical controls that we would treat with high-dose cyclophosphamide, suggesting that even in a population of complex and rather aggressive lupus that we see in this country, low-dose cyclophosphamide might be usable. And I suggest that you consider this when you're thinking about treating your patient, because then it decreases the overall cytotoxic burden of an alkylating agent, which of course affects sterility or fertility, and perhaps in high doses later on predisposes to leukemia. Okay, and then you go to a maintenance phase where prednisone is lowered and you maintain patients with MMF or azathioprine or cyclosporin or tacrolimus. These are kind of secondary if MMF or azathioprine is not tolerated. Okay, so what about a steroid-sparing protocol? Does that really exist? And the answer is not yet, but maybe. Liz Lightstone is a nephrologist in her group at the Hammersmith, and they've been working with steroid-sparing for some time because steroid side effects are one of the biggest problems that we have, both short-term and long-term, with our lupus patients. Nobody wants to take steroids if they can avoid it. So this is a single center cohort study. These were biopsy proven class 3, 4, or 5 lupus nephritis. They had not been on steroids, so these were new patients. Rapidly progressive loss of renal function patients and patients with CNS lupus were excluded. The patients were given 2 doses of rituximab. So everybody knows rituximab is an anti-B cell drug. They were given 1 gram plus 500 milligrams of methylprednisolone on day 1 and day 15, and then immediately were put on maintenance dose mycophenolate mofetil. Okay, no oral steroids were given to these patients. So this is not a completely steroid-free protocol. There were 2 doses, high doses of methylprednisolone given 2 weeks apart, but no oral steroids were used in these patients. And she presented the original results a few years ago at the ASN, and then she, a year or 2 ago, presented the follow-up study. And these patients now are followed for 5 years. The median follow-up was 77 months, actually. This was a cohort of 50 patients, mostly women. Now, you can see that this is not the same ethnic mixture that we would see here. A lot of the patients are Caucasian, and then a lot of patients are Asian Indian, so South Asian. A nice mix of various classes of GN, of lupus nephritis, and they followed the patients, 42 patients for 77 months median. And these were the data. 38% of the patients achieved a complete or partial remission. And you can see how the remissions were distributed by class. The median time to remission was 9 months. This is actually the same median time to remission that we see in our cohort using oral cyclophosphamide in aggressive doses. Okay? So these were renal flares in their population. A median time to renal flare was about 24 months. This is how the patients flared. Class 4 patients, not unexpectedly, flared more. This was a little unexpected. Class 3 patients flared less, although there were fewer class 3s. There were 19 total renal flares. 80% of them were managed without the addition of steroids. The go-to drug when you have a renal flare, currently, is increase corticosteroids or add them back if they were tapered. About 70% of the patients were retreated with rituximab. They didn't have a lot of extrarenal flares, and they were able to treat those mostly without steroids. So what does this have to do with anything? Well, now that they have this pilot data from England, we have created a study called Rituxaloop. And it has just enrolled its first patient in Europe. We are OSU is the coordinating center for this trial in the United States, and we're about to start getting our sites up and running. So there actually may be a steroid-free protocol in the future, or a steroid-minimized protocol in the future to offer patients like our patient here who may not want to take corticosteroids. Okay. So let's finish up the case. She agreed to be treated with MMF and steroids. I don't think we can treat her off protocol. We did rapidly taper the steroids, and we started out with a lower dose than usual. I will point out that in the United States, we tend to start our corticosteroids at 1 milligram per kilo per day. In Europe, they tend to start at about 0.5 milligram per kilo per day, which ostensibly will be better tolerated. After 6 months of treatment, her creatinine was 0.9, her proteinuria had declined to 1 gram a day, and her complement levels normalized. So she's doing pretty well. 12 months later, her creatinine was 0.8, proteinuria was 250 milligrams a day, and she was feeling well, had no extrarenal symptoms. 3 years go by. She's feeling very well. She was married. She wants to have a family. Creatinine, C3, C4 are normal, and she has no proteinuria. So what do you tell the patient now? Okay? Get rid of the MMF, change immunosuppression to cyclosporin or azathioprine, avoid pregnancy. And you may say, wow, who would tell a patient that? Well, I unfortunately see a lot of patients in my clinic who've been told never ever to have children, and this is a big deal because that's important to many, if not most people. So we can cross D out right away. Or E, repeated kidney biopsy to inform treatment decisions. So if you haven't gathered it by now, we biopsy everybody. I mean, if you happen to see me, you might get a biopsy, just if we were exchanging pleasantries. So we believe a biopsy is safe and very informative. And I want to bring this up and leave you at the end with possibly a new paradigm of how we should manage the long term of lupus nephritis. How long is maintenance therapy? Well, we don't know. After a complete response, it is suggested that maintenance therapy be continued for at least 1 year before tapering the drugs. Now, I know who wrote that. It was me. It's in the KDIGO guidelines, and that is based on absolutely no real evidence. Okay? And we say that in the KDIGO guidelines. We grade these recommendations. I reviewed everything that existed when we wrote those guidelines on maintenance therapy. The duration of maintenance therapy in 7 randomized controlled good clinical trials, median duration 3.5 years, or mean was 3.5 years, median 2 years, range was 1.5 to 7 years, if ever. You talk to some of my rheumatology colleagues, never take therapy away. That's a problem because I suspect you don't want to treat your patient. I wouldn't want to be treated with immunosuppressive therapy forever if I didn't need it. And these were the trials that I quoted in case anyone wants to look these up. So how do you really decide when you can get rid of maintenance therapy? So let me throw this out to you. Could we use a repeat kidney biopsy to determine the length of maintenance therapy? So let me show you some data. This is in collaboration with a group in Argentina who routinely does repeat kidney biopsies. So we don't do this very often in the United States. Serial kidney biopsies were done in a lupus cohort, 25 Hispanic patients, female, young. This was the timeline. Biopsy 1, diagnosis. Biopsy 2, after 6 months of induction therapy. Biopsy 3, during maintenance therapy, after 42 months of total treatment and at least 30 months of clinical inactivity. Okay? So these are patients that I think all of us might consider being in good shape to take therapy away. These patients were treated just like we treat patients, IV cyclophosphamide or MMF. The correct doses, they were maintained with MMF or azathioprine. These are the data. This is change in serum creatinine and proteinuria at the 3 biopsies. You can see serum creatinine comes down nicely. You can see that proteinuria resolves. These patients did very well. Complement C3 improved. Complement C4 improved. So these patients had a good response over the course of this treatment. And this is biopsy 3. This is after years of therapy with almost 3 years of no clinical activity of lupus or lupus nephritis. I want to mention that. Lupus or lupus nephritis. So they didn't have extrarenal symptoms either. Okay? It turns out that in the group that would have been considered a complete responder group by everyone in this room, based on the criteria that exist right now, there were a lot of patients that had an activity index of 0 on their biopsy, but about a third of the patients had an activity index greater than 3, despite no clinical evidence of active disease. So I want to get back to this idea of discordance between the biopsy, what's going on in the kidney, and the clinical findings. It's significant, and it can be significant even in the long term. Okay? Partial remitters. This is even more confusing. So the idea is if you don't have a complete remission, maybe you should keep a patient on immunosuppression forever. But sometimes you have proteinuria that's just there because you have glomerulosclerosis or nephrosclerosis, so you have scar left over from the initial inflammatory insult. You think it's active disease clinically, but look at the partial remitters. A lot of them had absolutely no activity either. So you could theoretically say, well, their disease is under control, we could taper as well. Okay, so this is my last slide. I'll throw this out. We've actually published this in a rheumatology journal. We'll see how what reaction it engenders. We have a lupus patient who develops new proteinuria, hematuria that's glomerular or renal insufficiency attributable to lupus. We believe you should perform a kidney biopsy at the beginning for a diagnosis. You do induction and maintenance therapy as they exist today or as they'll exist in the future. And if you have no response or a partial response, consider modifying the therapy. And sometimes we would like to repeat the biopsy then to see how we would modify the therapy. If you have a complete renal response and then you flare, we generally will repeat the kidney biopsy, especially if it's been a long time between the remission and the flare. These are not unusual types of things. Many of us do this in our practice. But if you have a complete renal response and you stay in complete renal response and you want to stop the therapy, consider performing a kidney biopsy. And this is where I think we'll meet with a lot of resistance because we say we don't want to do that in a patient that looks good clinically. But as I showed you, they can still have ongoing inflammatory disease. Now, the real answer to this question is to work with the people in Argentina who do this on a routine basis and then divide these patients up into people who have a biopsy and people who don't and make your decision based on the biopsy versus your decision based clinically. They consider it unethical to do that trial, even though I don't think it's unethical because we don't know. If they find inflammation on this biopsy, they continue maintenance therapy. So I think with that, we're almost on time, and I'll finish up. Thank you.
Thank you. That was wonderful. I have a few questions, but I'll just start with two.
Okay.
Before we open it up to the audience. So you mentioned this relationship between lower levels of estimated glomerular filtration rate and cardiovascular risk.
Yes.
And of course, we don't know that that's a causal relationship, a direct causal relationship. Is there data that if I bring up again GFR, if I normalize it, my cardiovascular risk normalizes?
So you're So I don't know that we know the answer to that question because we've looked at this in the CKD population. And in the CKD population, we mostly can't get that GFR fixed. But in the AKI population, so the acute kidney injury population, we now know that even though you can normalize your kidney function, you're at risk for developing chronic kidney disease, higher risk for developing chronic kidney disease down the road. So my suspicion is the answer is going to be no. So fixing it isn't probably as good as preventing it.
The second question I have for you related to the biopsy. You advocated for having a biopsy to decide diagnosis, decide changes in therapy, or even to decide discontinuation.
Yes.
Tell me more about the complications of kidney biopsy.
Well, you got your wonderful team here. There are no complications, right?
Next question.
Okay, yes. So, well, what Ken just brought up is a huge issue. In almost all centers that are not academically related, nephrology is no longer doing kidney biopsies. Madam President, I think that's wrong. She's going to be president of ASN shortly. She's really looking forward to getting my emails when she's president of ASN. So for the radiology biopsies, we do see the following complications. They often go very deep, so there is some bleeding. Most of the time, the bleeding's not a big deal, but what they do is they get very little cortex and a lot of medulla, which may not be sufficient to make a good diagnosis. Now, there are mathematical models to predict how many glomeruli, et cetera, you need to be confident in your diagnosis. For the interstitial disease, we don't know that. Okay, interstitial disease is much more difficult, and I think we miss a lot about the interstitium in kidneys. That's an aside. In a good operator's hands, the complications of biopsy are local pain and gross hematuria. That happens in maybe 10% of the cases. In a very small percent of the cases, that hematuria doesn't stop, and then we need to embolize a portion of the kidney. I think that happens in probably 1% or less of the cases. And mortality, I mean, in the time we do about 120 natives a year. In the time I've been doing it at Ohio State, we've had one death, and I've been there 25 years. So mortality is a possibility. So it is not. Don't take me wrong. I don't biopsy willy-nilly. It's not a benign procedure. There's no question. And can I use that to segue into biomarkers for a second? That really brings up the point is if the histology of the kidney is really important, and I think it is, in helping us decide prognosis, treatment decisions, et cetera, then, and of course there is some risk to doing an invasive procedure with a needle in somebody's back in a vascular organ, the idea of finding biomarkers that actually reflect what's going on in the kidney so you can follow that serially is really optimal. And so that's what John Klein and other colleagues that I'm working with here, you said I do mass spec. I don't do mass spec. They do mass spec. So we collaborate. We've been working together for years. So we actually are looking at the pathology of the kidney right now and looking at the proteome of the glomeruli and the interstitial space to find markers that are in the kidney, and then we're going to see if they're actually excreted in the urine. Can we work those up into viable biomarkers that reflect histologic patterns? Not class 1, 2, or 3. I don't like that. Inflammation, fibrosis, crescents, necrosis, things that we are worried about. Resolution. So I think that's the real answer. The real answer is I don't want to biopsy everybody every 3 months, okay? But what I do think is what these repeat biopsy series are showing us is that our ability to assess what's happening in the kidney based on clinical parameters alone is very poor.
Question. Let's start here. We go around the auditorium.
So you showed the discordance in clinical remission on therapy with pathology, but earlier you showed the 70% patients following 7 years from the ROC, showing some predictability of how people are going to do on
Yes.
clinical markers.
Yes.
What are you wanting to drive home there about when to move
So what would be ideal would be that we would have both the histologic and clinical markers together. We don't. What I wanted to drive home with that is, can we have something early on that we can use in clinical trials to qualify new drugs? Clearly, we're not going to capture everything correctly, I suspect. And I think what we'll probably have first will be the clinical markers. What I would like to do is do the trial that I mentioned, because you talk to my old chief of nephrology, who's emeritus now, and he said, I don't care if there's inflammation on the biopsy. He said exactly what you're implying. If the proteinuria is under control, these patients are golden. And they may be. And that may be the suggestion from that reanalysis of the ELANT trial. So I'm not sure. Okay. So that's a great question, and the answer, I think, is no, including me. And I'll tell you the reason for that. So I don't believe that in this particular trial that I showed you, the rituximab is an induction drug. I believe rituximab is an immunomodulatory drug that will prevent the next flare. I believe rituximab is a maintenance drug. I think, the only reason she got away with this is because 2 large doses of methylprednisolone are so anti-inflammatory that she buys time for the mycophenolate to kick in. Because essentially she's giving mycophenolate, which is an induction drug, right away. So I personally, and I've written this, don't believe that this should work. And I'm not sure it's going to work in our population, frankly. Okay, so that's slide 1. Slide 2 is there a way around the steroids that might allow us to use these sorts of things? And I'll use the example of laquinimode. Laquinimode is a fairly novel oral anti-inflammatory drug. It inhibits NF-kappa B, which is a transcription factor for inflammatory cytokines. And it's been shown to have some efficacy in MS. They're trialing it. We did a trial of this in patients with lupus, and it was one of the only positive trials we've seen. It was a phase 2, but after six months, the patients improved more than placebo. So to me, that's an indicator that we can use other anti-inflammatory drugs to substitute for the because that's primarily what steroids are doing, especially the high-dose steroids, is anti-inflammatory right at the beginning in an inflamed kidney. So I think if we can get these things out there, there's a chance that we could change the induction regimen and eliminate steroids. But the honest truth is, one of the biggest problems we have in clinical trial design now is that nobody will back off on steroids in this country. And so we always have a background of high-dose or moderate-dose steroids in the clinical trials. I think this is a unique trial. I am worried about it, and there are only 4 sites in the United States. They were my site and 3 others that I handpicked that would actually take that sort of risk.
Last question and a quick one.
Like Dr. Rovin, I was impressed with the engagement for the individual medicine clinic puts in a lot of time to obviously cardiovascular
Yes.
and that's with the lifestyle
Yes.
but the models do not factor in.
Yes.
I had always thought that that was due to the fact that there was lower diagnosis
Yeah, I think, when you look at chronic kidney disease and you look at our population of patients, I think there's an underlying continuous low level of systemic inflammation. And I think this damages the endothelium. And I think you can see this even in our dialysis population where premature cardiovascular disease is rampant. And so I think, I realize the formulas don't include CKD. Maybe they should. But if you look at many of the cardiovascular trials, we tend to exclude patients with significant CKD because they just complicate the trial. So I suspect we don't have the data to include that in the formulas.
Okay. Well, I really thank you for being here. I don't know if you're a baseball fan, but we want this in your office so that when the new dean walks in and out or out, he or she will show some respect.
All right. Wow, this is...
Brad Rovin, Medicine Ground Rounds, University of Louisville, May 28, 2000.
Wow, this is great. Thank you.
Thank you all.
I'm a Cubs fan, so I'm the worst.
That's my